So hi everyone, welcome to another Monty Heart lecture series. It's a great pleasure to have today Dr. Parwani, who will be presenting about the ACC AHA guidelines for perioperative cardiovascular management for non-cardiac surgery that was just published. It's a real honor to have her here today. Dr. Purvi Parwani is an associate professor of medicine at the Loma Linda University and the director of the Echo Lab and Cardiac Imaging Services at Loma Linda University Health. Her clinical and research interests include advanced cardiac imaging, including structural echo and CMR and women's cardiovascular disease. She's an immediate past early career chair and board member of the Society of Cardiac MRI and serves as a member of the ASC and ACC Imaging Leadership Council at the ACC. She has contributed to these guidelines as she will be speaking today and many others. And importantly, she has received recently the Woman of Distinction by California Legislature Assembly this year, right? Was that this year?
2020.
2020. Well, congratulations on that and welcome to New York. She will be speaking in person today.
Thank you, Leandro, for that kind introduction. Very excited to be here. You all have a great team. And so although, I'm an imager, I thought that we would pick this very recent topic because the guidelines was released day before yesterday. And I had been serving on the writing committee when it came out. So I thought it would be a great kind of introduction to what are the new things that got released. So last guidelines were in 2014 and, these guidelines, 2024. So 10 years, wealth of knowledge, lot of new data, and this is why I chose. So I think the guidelines are wide. So what I've done is given you 10 take-home points, and we are going to discuss through the 10 take-home points in this 50 minutes of presentation. So my first take-home point is probably you all are very aware of. Risk assessment is important. So when we are seeing patients for perioperative evaluation, patients that are low risk and going for low risk surgery do not need any further cardiovascular testing. So of course, we all have seen as, imager and cardiologists, the misuse of cardiovascular testing, which of course we are well, aware of, and cost consideration is important in medicine. So let's discuss what is the risk assessment? How would you decide who is low risk patients and what are the surgeries that are low risk surgeries? So everything starts in your clinic. You get a patient with symptoms, the right medical history, you have vitals, you have physical examination where you can detect what is the cardiovascular problem patients may be presenting with, or maybe they're not presenting with any. But what guidelines tell you, a two-way recommendation to do risk assessment, functional capacity assessment, frailty assessment, which is a new recommendation in this guideline for anyone that is more than 65, or if they are less than 65-year-old, then, but if they appear frail, you'll do frailty assessment, and if they have symptoms suggestive of cardiovascular disease, getting an EKG. So not EKG for every single patient that walks in for pre-op, but rather focusing on the patients that truly need it. And we literally spent probably like a month talking about EKGs because it's a very misused test, although it is very cheap. So all of these recommendations have been given two ways. So let's go through it. So I guess when we talk about risk assessment, there is patient risk and then there is surgical risk. And we're going to speak about both. So when we look at the patient risk, we are all very aware of the RCRI score because we use it very commonly. We cite it in our clinical, notes, etc. There are 5 tools that guidelines have shown you. I've just shown you 2 here. The NSQIP, which is widely used by the anesthesia practice because it has 21 components. The shorter one you may know as Gupta score. So anesthesia uses it quite a bit. We, I think in cardiology, more commonly use RCRI. It's simple to process, you get the risk. The common thing about all the risk assessment tools is it's divided into less than 1 and more than 1. So there is no intermediate risk and high risk. It's either low risk or not low risk, which is all high risk, okay? So keep in mind. Of course, when we look at the RCRI, the clinical variable that matters is ischemic heart disease, congestive heart failure, stroke, any studies that you take, all of these risk factors, diabetes, CKD, have been associated with more risk of mortality. And this is why it is important. So you decide first whether the patient is low risk or high risk. Then you decide on the surgery. Is the surgery low risk or high risk? So let me tell you, all your cataracts are low risk. Breast, any breast surgeries are low risk. Any OB surgeries are low risk. And your high risk would be your solid organ transplant, the patients that we see very commonly, your vascular surgeries. An important thing to keep in mind that you may be dealing with a low risk surgery that has potential to become high risk if they open up the patient and not go, minimally invasive. So keep that in mind. But I think it's important to indicate your patient risk as well as surgical risk, depending on what the patient's coming for. Now, the new thing with these guidelines is DASI score, which I'm not sure how many of you are aware of, has been given a two-way indication. So what is DASI score? It's a functional capacity assessment tool that was actually, I think it was a Duke paper that came out where they have all these components that you can incorporate in your note. And why they're giving DASI score 2A recommendation is because we know that, number one, when patients have inability to walk, they are not able to walk, they are not able to do their routine, they have higher mortality in perioperative period. And number two, this Lancet paper that I've quoted here, when you do subjective assessment, when you just ask the patient, are you able to take 2 flights of stairs, or can you walk 4 blocks, which is consistent with 4 METs, which has been associated with low versus high functional capacity, that is actually not as good as doing a comprehensive assessment by doing all the components that I've suggested it. So particularly for anesthesia, we know that, when anesthesia attendings are seeing these patients, they are going more into complete assessment, and using all of this. So now, based on these guidelines, what you can do is create a smart phrase and come up with the DASI score in your note when you're doing pre-op assessment and decide if it is truly, patient that has functional capacity or not. Now, frailty assessment is completely, oh, what happened?
Maybe if you accept it,
Allow or
maybe
deny?
allow, yeah. They're not seeing there, maybe yes. Do you see it now?
It's probably this, go to the bottom.
Oh, it's.
Sorry.
No, you can share again.
Okay.
Share again.
Sorry, guys.
Yeah.
Hmm.
Yeah, it's just right there.
No, it's not working. Okay, perfect. Thank you. So frailty assessment is a new recommendation in this guidelines, and again, given two-way recommendation. And why it has been given two-way recommendation is because we have multiple studies and meta-analysis indicating that when patients are frail, they don't do well post-operatively. And in fact, when you do the frailty assessment and decide whether the patient is frail or not and do rehabilitation based on that information, patients may do better. And this is the data that has been, shown. So prehabilitation before the non-cardiac surgery, or maybe you go all the way on the other side and decide that this patient is too frail and we need to discuss the goals of care, right? So it's either ways, but nonetheless, it also gives you all the assessment tools. I think out of all of this, clinical frailty scale has performed well in the studies. So just keep that in mind when you are seeing these patients. Do the frailty assessment when these patients. So number 2, cardiac biomarkers are useful. So don't throw tomatoes on me. I know we all have love and hate relationship with troponin, but I'll show you the data and I will tell you why this has been given a recommendation. So BNP is the 2A recommendation in the new guidelines, and troponins are 2B recommendation. These are absolutely new. They were not included in 2014. And I will tell you that European guidelines have class 1 for both of these biomarkers. So we are really like taking a seat back because we understand what troponin measurement can do to our healthcare, right? So I think these are the recommendations. I'm going to read it out to you because it's important. In patients with known CVD, so anyone with cardiovascular disease, anyone with more than 65 or more than 45 that have cardiovascular disease, that are undergoing non-cardiac surgery, elevated risk non-cardiac surgery. So these are not the low risk. We already decided low risk, we are not going to do anything, including biomarkers. These are elevated risk patients. You do BNP before the surgery because it's going to supplement your evaluation by, that you do by RCRI or by any other risk markers. And for the same, thing, we have given 2B for troponin. And let's talk about it. Now, just to tell you, there are no studies so far to show change in mortality based on the biomarker, although we have tons of data that these biomarkers are prognostic in perioperative period. There are no studies that have tested it in the patients. And then again, to reiterate, you are not going to do it in the low-risk patients. So this is only for elevated risk patients going for elevated risk surgery. So that's your solid organ transplants, that's your vascular surgery, etc. Okay, so let's look at some data. And of course, there are so many papers on this, and I have just highlighted a few important ones. But if you take BNP or if you take troponin, we know that when you add it with the RCRI score, it incrementally makes your risk assessment better. And it reclassifies your patient into low versus high risk. And the numbers here are not negligible. When you use pro-BNP, almost 258 patients per 1,000 got reclassified into new risk. And same with troponin, T or even the high sensitivity troponin, same data, that when you use it, it does have incremental value on your risk assessment. And I will show you in a minute how none of our imaging testing have any incremental value on the functional assessment tool like RCRI. So I think what guidelines are saying, do the risk assessment, use your tools like RCRI, and then do biomarkers and accordingly decide whether that patient is appropriate to go for surgery or not. So avoid overscreening. So this is where we are going to discuss the stress testing, and stress testing in that bucket, echo, CT, MRI, everything. And I'm going to touch upon at least, echo and CT. So I think that we all know that there are a lot of patients that are getting non-cardiac surgery. And most of our patients that we are seeing beyond 45, 45% of them, almost half of them have cardiovascular risk factors. And more importantly, they have atherosclerotic cardiovascular disease. And we, when we read CTs, we know, when we do calcium score, we know these are not low-risk patients. They do have atherosclerosis. And the surgeries, as I've told you, vascular solid organ transplant remain the most high-risk surgery. And if we look at the big data analysis since the early 2000s, there's still mortality still remains kind of steady. Although we have invent of GDMT and we are doing so many things in medicine, the mortality has not decreased in the perioperative period that tremendously. The curves are still kind of going at the same pace. In fact, for stroke, the mortality relatively has kind of stayed up or gone up, and it has plateaued. So we definitely can do better. And what's happening? We are testing way more patients, right? We are doing way more with GDMT. Why are these patients not improving? Because we are underutilizing the things that are protective and overutilizing the testing. And, so let's look at the data, right? So this was the study, believe it or not, these are the studies that are quoted in 2014 guidelines. Thallium study, 53 patients. On the first one. On the right side, Mayo Clinic stress echo study, 530, published with Dr. Pellica, etc. And, my favorite people. But this is observational data. And what they showed was the bigger the defect on the stress testing, the worse your patients did. And that makes sense. We know that, that has been correlated in multiple studies. But the question is, does that information add beyond the risk assessment you have done for your patient? Does it give me any more information over what RCRI is telling me, right? So these studies were quoted in 2014 guidelines, and 2014 guidelines, just to revise what they said, you all know this, you assess the METs. If the METs is poor and your patient, is going to get better by doing stress testing, you can decide to do stress testing. And that was a class 2A recommendation. And this got flooded in every stress lab around the country, right? We all started doing stress testing after stress testing every year for kidney transplant. I'm sure, we are a big dobutamine stress echo center, and, we still do 10 studies a day. And I'm not sure how many of them are truly adding to anything. But, this is the hard part. We have to convince the surgeons, right? So 2014, guidelines. My father is surgeon, so I agree with you when you say impossible. 2014 guidelines, stress testing was the mainstay of diagnosis, right? And this has changed in these guidelines. So why it has changed is from 2014 to 2024, we have multiple big data analysis done in from orthopedic surgery to your vascular surgery to your transplants. No benefit at all beyond your risk assessment tools with stress testing. So in spite of doing, stress testing, in spite of making sure that we have enough information, we are not able to change mortality for these patients. Then why are we doing it? Let's go one step beyond. So, we of course are very well aware that none of these trials in PCI population have shown any outcome benefit and multiple meta-analysis. And we're very clear in chronic stable angina population, chronic CAD, it's not beneficial to do revascularization. And in fact, this was tested in an NEJM trial that some of you must be aware of, the CARP trial, that took very high-risk vascular patients, decided to revascularize them, and did not see any benefit with revascularization, right? So similar theme as, ischemia, revived, courage, everything, similar theme, no benefit at all. Important to remember, CARP trial excluded left main, and patients that had low EF because of ischemic heart disease. Now there's a difference, right? Don't mix the mixed cardiomyopathy in this category. When you have low EF due to ischemic heart disease, those are the patients that were excluded. Severe AS was excluded. In fact, look at this, right? So earlier, for surgery, what matters is the short-term mortality. And look at these curves. Although they were not significant, you can see the worst curve with coronary revascularization in that early period. So the jury is still out there. There are no other revascularization guidelines. The studies, randomized controlled trial in perioperative period, there are some going on, but this study showed very clearly that high-risk vascular surgery patient, you don't do any benefit to the patient by completely revascularizing them, apart from that left main. So this is a left main patient, that I saw in the lab the other day. You can see, normally it's moving at peak stress, it's global hypokinesis. So, these are the patients that are coming about. But, what the point I'm trying to make is it's unclear if abnormal stress test provides any incremental value over what your RCRI is going to do. And I already showed you the biomarkers do have incremental value over your RCRI or risk assessment tool. And more importantly, revasc is not going to decrease your mortality. So who are the patients, whether it's utility in doing stress testing, are the patients when you suspect really severe CVD, whether it is left main or triple vessel disease leading to low EF. It's difficult to suspect it, when all your kidney transplant patients are in high risk. So that's the difficult part. And I agree with that, although this is what we are saying at this point. Now, we all love CT, particularly in this center. I know how much CT you all are doing. So CTA Vision, decided to, use CT in the perioperative period, and it showed that, yes, you can figure out with the patient's single vessel disease versus multi-vessel disease, they had higher risk. So if they had single vessel disease, it was 3x risk of mortality, multi-vessel disease 5x. So it definitely gave us the mortality curve according to the atherosclerotic level. However, CT is a very sensitive modality. So it basically overestimated the risk in the perioperative period. And hence, the guidelines have given CT also 2B recommendations to be done. So both stress test and CT are downgraded. Well, CT was never there in 2014, but stress test is downgraded from 2A to TB, and CT is downgraded from 2B. And, we all know there's value in identifying that left main disease on CT, then, it's difficult on stress testing. So you can, more importantly, if your calcium score is 0 within the last 2 years, it's okay to proceed with surgery. Again, you'll have difficulty convincing a surgeon that CAC is 0, so let's go for surgery. But I think this is where the education is important, to share data with them is important. So just to reiterate, same as 2014, no class 3 recommendation for doing routine angiogram on these patients. And then, at the same time, I want to make sure that you all understand that if there is any risk of MI, that patient is worse mortality. If there is any risk of PCI, that patient does have worse outcomes. And risk of MACE is actually proportional to when the cath was and PCI was done. And doesn't matter whether the PCI was done for chronic angina or for ACS, because once you have PCI, that patient is at higher risk of getting thrombotic complications, bleeding complications. In fact, the risk was proportional to the time when the PCI was done, regardless of for what reason the PCI was done for. For unprotected left main non-randomized trials, have tested CABG, and it is good for, it improves the outcomes. And so we think that PCI would do the same for left main disease. Okay, so this is the algorithm that you all are waiting for, and I'll point out to you where things are different. So of course, this part remains the same. If you have emergent surgery, proceed. If you have any patient with ACS, you're going to accordingly manage that patient. You're going to assess the RCRI score. You're going to figure out if the patient has any of these things, which is valvular heart disease, pulmonary hypertension, etc. Okay, so you go beyond that. You decide that this patient has poor functional capacity by DASI, and then you decide that, yes, further testing is going to make a difference. First thing you do is biomarkers, and pro-BNP 2A, troponin 2B there. And then if the biomarkers are normal, you don't do anything and proceed to surgery. If the biomarkers are abnormal, you're going to discuss in a team fashion if doing stress testing or CT is going to change anything. And even if your CT or stress testing is showing abnormal findings, you're only going to do revascularization if it is truly high-risk findings. And we all know what is the high-risk finding. So if it's a small extent of ischemia, whether it is nuclear stress test or dobutamine or one vessel disease on CT, you're going to try to use GDMT and not do any revasc. So it's kind of like changing, everything that we have so far done in preoperative testing, and only revasc recommendation if it is left main or multi-vessel disease that is going, that is leading to less than 20% EF. So these are the cutoffs that for BNP they have given. And I think why they stress the troponin is because once you have the baseline troponin, you can actually check the troponin in post-operative period and decide if it is truly an MI or not, right? So some patients will have chronic myocardial injury. Any patient with amyloidosis, severe HCM, they may have truly myocardial injury, and you can make sure the surgeons are calm that this is truly myocardial injury and you don't have to act on that troponin. And this is why they stress on baseline troponin level. And we'll discuss this more in the discussion part. So now let's go. So you have now seen the algorithm, and I'm now just going to quickly go through the medications that are important. So optimal blood pressure control is crucial. Both hypertension or hypotension has been associated with worse mortality. And the guidelines here are almost the same. The main thing I've highlighted here is like anytime patient has hypertension, you're going to continue the medicines. Anytime they have really bad hypertension, more than 180 by 110, and they have elevated risk, you're going to hold off on surgery. And remember that there can be situational hypertension because they come with the anxiety on the day of surgery. That's not what we are talking about. We are talking about the baseline blood pressure at home. You're going to maintain those MAP and SBP levels and, treat hypotension as it is required. And finally, when you go to see that patient in consult, you're going to start the meds. If the anesthesia is holding off, you're going to restart them as soon as possible, because we know that these meds protect our patients in the perioperative period. And this is my next point. GDMT for heart failure works. And it's very important to understand this. So, heart failure literature in perioperative period, when you look, regardless of the EF there is there, whether it is 30% EF or 50% EF, all of them have bad outcomes. So, anytime you're taking any patients with a label heart failure, whether it is preserved or reduced, you are already representing worse mortality for that patient. And the guidelines say that you're going to continue GDMT in these patients, except for SGLT2 inhibitors. So SGLT2 inhibitors have to be held 3 to 4 days before the surgery. And why that is because they have a higher risk of leading to acidosis. So apart from SGLT2 inhibitors, you're going to continue all the GDMT. In fact, they say the same thing for diuretics as well to ensure that that patient has optimal management before they go for surgery. In my hospital, I've had some issues with hypertrophic cardiomyopathy patients going to surgery, like the anesthesia freaks out. You have to, make sure that they are doing okay. You have to put all these recommendations. So I'm so glad that these guidelines addressed hypertrophic cardiomyopathy in a more systemic manner than just writing a paragraph. And we have all the things that, if you look at hypertrophic cardiomyopathy literature in perioperative period, these patients actually do well. Now, we don't have randomized control trials, but we do have observational data that they don't have worse mortality. It's all about hemodynamically managing the patients. So for all the fellows, these are like your board 101, use alpha agonist, use more fluids. This is all tested in boards, but this is the important recommendation that you are going to put in your note when you're going to assess these patients in perioperative period. So take home point 6 is, again, medical therapy has an impact on your patient outcomes. And here, medical therapy, I just mean risk factor management. So all your hypertension patients need to be on optimal hypertensive medicines. All your diabetic patients need to be managed carefully. All your patients with mixed hyperlipidemia need to be on statin. And so there is class 1 recommendation to continue statin, but also if your patient is coming to you for the first time and they are not on statin and they are eligible for statin, you're going to start them on statin because we think that this is the opportunity for clinician to meet that patient. And this is the opportunity we all have to reduce the patient's overall risk. So, we should do that. Now, the thing is that they don't want you to hold off on surgery while you check their LDL, but they want you to continue doing that. There is a small trial of 500 people that showed that, in fact, when they come in perioperative period and you reload them with statin, you increase their statin dose, they actually do better with AFib and a hospital stay, etc. But because it was a one trial, it didn't make it to any recommendations. So it's important to, just make sure that these patients are optimized, even if they are just coming to us for the quote unquote clearance. It's our responsibility to make sure they are treated. Same with diabetes. We are giving you need to check HbA1c. You need to, again, hold off on that SGLT2 inhibitors, as I said. And then more importantly, if they're on Wegovy or Ozempic, any GLP or agonist, you have to hold 1 week before because there is gastric emptying is affected and these patients are at higher risk of aspiration if you don't hold it. I think we went back and forth, with multiple guidelines and statements on metformin, and there's a two-way recommendation to continue metformin. So now multiple studies kind of clarifying stand on metformin. You don't have to hold metformin with a risk of acidosis or anything, but you would do that for SGLT2 inhibitors. So I think take home 7, I think the fellows probably know this very well, the antiplatelet and anticoagulant management. And this is important, right? So I think it's not much different than 2014, kind of the same. So let's go one by one. So the timing for the PCI is kind of the same. If you have bare metal stent, you're going to delay the surgery 30 days, balloon angioplasty, 14 days, and then ACS, absolutely 12 months unless you have to do something about it, okay? So class 1 recommendation, no change at all. More importantly, for the fellows, any prior PCI, continue with aspirin. And I see so much variation even with the cardiology community that I thought it was important to state it again here that these guidelines remain the same. Anytime you discontinue their oral anticoagulant, you're going to put them on aspirin to ensure that they are on something, particularly if they have prior PCI. You don't have to start aspirin if they don't have prior PCI. So there's no data from POISE trial to suggest that aspirin actually helps. So do not start them on aspirin unless they meet the indication of aspirin with prior ACS or PCI. And then routine bridging with IV Antiplatelet antiplatelet is not indicate, at least we don't know of any data for non-cardiac surgery, although we do it routinely for our CABG patients based on the bridge trial. So remember, you can do it, case by case basis after consulting with your interventional cardiologist, but there's no guidelines on this because we don't have any data. Okay, finally, this is the same, the higher and thrombotic risk, your mechanical valves, your strokes, you're going to bridge them. Otherwise, routine bridging is not recommended. So any AFibs, you're just going to stop their anticoagulant and start it again in perioperative period. So these are the only things where you're going to bridge, and the guidelines give you really nice, kind of schedule on how you're going to do that. But apart from that, no bridging necessary. Okay, take-home points is the thing that you probably are waiting for. Myocardial injury after NCS, also known as MINS, a new term that's introduced, for these guidelines, at least, although the phenomena has been described since 2000, has more than minimum impact. And what this is basically your troponin leaks after non-cardiac surgery. And now it has been given the recommendation because we have literally close to 200 papers on this topic showing that troponin is such a good prognostic marker. So you cannot ignore all that data, although we don't know what to do with that information. We cannot ignore that data. So let's just go through this, right? So anytime your patient has troponin after non-cardiac surgery, if they have STEMI, you're of course going to take care of that by STEMI recommendation. If they don't have STEMI and you think that they have NSTEMI, we downgraded the revascularization to 2A. So it really depends if that patient has cardiogenic shock, if they are persistently hypotensive, if they have persistent chest pain, that's when you're going to send them to cath lab. Otherwise, you can do GDMT and be okay with it. And in fact, GDMT for all these patients have been given class 1. So that's a big difference in the NSTEMI management. And we argued a lot on this because we know a lot of people get labeled NSTEMI when they're not true NSTEMI. It's not a plaque rupture, and we understand that, but still they go to cath lab and there is, misuse. Anyway, so post-operative myocardial injury, that is not STEMI or not NSTEMI, just your troponin, that's the one we're seeing that these patients need to come back to your cardiology clinic. And what are you supposed to do? You're not supposed to send them to cath lab. You just have to risk factor modification, and you have to make sure that they are in best cardiovascular health. And that's what all it is. So this is a very heterogeneous population. So if you take a patient that has maximal GDMT already, I'm not sure what you're going to do with those troponins because you have made sure that that patient is on everything. And GDMT is aspirin, statin, and whatever antihypertensives that you can recommend them. But more importantly, informing that patient that they're different than the patients that do not have troponin. They are at higher risk of getting cardiovascular events later in life. And they have to make sure their weight is optimized. They have to make sure their diabetes is optimized. That clinical information for our patients is very important. So this, class 2B indication to check troponin at 24 hours and 48 hours after surgery and, do that for our patients. And mainly it is GDMT and risk factor management. Now, there is one trial called MANAGE trial, which tested dabigatran, and it's 110 milligrams BID, so different than the AFib dose in this population, and showed that outcomes were better. But this trial was small. It had higher rates of, patient withdrawing and less follow-up. So it has not made it to guidelines. So that's the only data we have as far as the management of MINS is concerned. Okay, finally, post-operative AFib needs treatment and monitoring. And this is a new recommendation again, because now we know by a lot of data that anytime patients have post-operative AFib, they don't do well. So what you need to do is you need to bring those patients back. We used to think that, it's just one-time AFib with surgery. But we know that these patients have actually higher recurrence and they have higher stroke risk. In fact, they have higher stroke risk than general population in that perioperative period. So all the surgeons are going to fight you, but it's important to anticoagulate them because they actually represent higher stroke risk. It's important to do the TEE or CT for exclusion of thrombus because, again, they are at higher risk because of the entire coagulation pathway getting activated during, surgery. So it's important to make sure that these patients have anticoagulation, and you see them back in clinic to make sure they get the monitoring to ensure, the AFib surveillance because otherwise their outcomes are poor. Finally, liver and kidney transplant, that we all love doing pre-ops on that. They need special care, but AHA and came out with this special statement in 2022, kind of societal position paper on kidney and liver transplant, because there is wealth of information. And we have ischemia CKD that did not show any outcome benefit, with revascularization. And I can tell you the theme of this statement paper is same as what we discussed. Do not do any functional assessment or stress testing. Do not do any revascularization unless you have high-risk anatomy or large ischemia on your stress testing. So it's kind of the same theme, but I know that these are the patients that we deal with the most in cardiology clinic. And so I just wanted to put a plug in for these positional statement that you can review, in detail. So finally, I'm just going to go over the 10 points that I discussed with you. So risk assessment, remember to do it with DASI and not subjective. Frailty assessment for more than 65. Low risk patients, low risk surgery, no need to do anything, send them for surgery. Cardiac biomarkers with RCRI because they have incremental value. Do not do CAD screening with stress testing or CT unless you suspect left main or multivessel disease. No benefit of doing routine revascularization or cardiac catheterization unless you suspect left main or multivessel CVD. Optimal blood pressure, diabetes, and cholesterol control, GDMT, that matters for every single patient. No routine bridging with DOACs, aspirin for all previous PCI. And if there is recent PCI, avoid non-cardiac surgery unless you have to do it. Remember MINS, myocardial injury. Remember to optimize these patients. Watch out for that post-operative AFib. And finally, pay attention to your kidney and liver transplant patients, but still follow the same recommendations. That's it. Thank you very much.
Thank you very much, Purvi. That was wonderful. Let's see for everyone, if you have two computers, so we'll try to work on this. If you have any questions, please put them in the chat and we'll read them. You can start with the first one. Do the guidelines recommend using regular troponin in patients going for high-risk surgeries with CVD risk factors? Our institution does not use high-sensitivity troponin yet.
Yeah, I think they recommend troponin T. It's a class 2B indication, but I think when you are that consulting doctor, you can decide, whether you just want to stick with BNP, which is a 2A recommendation, versus check troponin. And I think it's the comfort that you have with your surgeon, whether you are going to, share the guidelines with them and what they're gonna. If you think that you're gonna check troponin and send every patient to cath lab, then that's of course not the whole purpose. Basically, the recommendation is you check troponins and BNP, and if they are negative, you send the patient for surgery. And if they're positive, then you just do GDMT evaluation. And if there is anything else needed, then you do the stress testing or CT, depending on what you decide. So I think it's like case by case manner. I would absolutely check BNP in every single patient, because that has been given to it.
I have several questions from Mario Garcia in the back.
Thank you.
So, I missed the beginning, apologize for that. So your approach obviously varies according to the electrocardiogram, right? To begin with, that's part of the
Yes.
assessment.
Yes.
Put that aside.
Yes, I discussed the EKG. Yes, yeah.
The question about the last thing, evaluation in kidney and liver transplant, not necessarily for management, but how about for patient selection, for transplant, for organ allocation?
No, I think yesterday I got the same question, right? Like if we realize that these patients that have high cardiovascular risk and we are not able to modify that mortality by doing anything except GDMT, do these patients deserve to go for a transplant? And is that based off, that organ that can go to a 25-year-old? And that's more of a philosophical question that, we are going to deal with in our community, medical community, surgical community. But I think we have to realize that, yesterday at Westchester, when I was giving this, the surgeon said that, well, I want to make sure that that patient is at the best survival before I send them for transplant. And I was like, this is exactly what I'm telling you. It's in your mind that by revascularizing, you are modifying the survival, except you're not. There is no studies to show that you're doing anything different than you would do with medicines. And these patients just represent a worse mortality because they have more atherosclerosis. So I think this is the thing. Philosophically, we need to understand this. Our surgeons need to understand this. And then I think we are cohesive. I think the problem is that anytime a surgeons ask for, like, okay, do angiogram, we will do angiogram because we are like, yes, please, yes, we'll do it, right? We need to stop that culture, right? We are doing routine angiograms when they ask for it. We are doing routine PCIs when they ask for it. And I think as a community, we need to come together and put our foot down and understand that we are not modifying the mortality. We are just misusing the test.
One last one. So last one, you talk about medication to fall, and I think we are now not thinking about pre-op clearance, about saying yes or no.
Yes,
For
absolutely.
Revascularization or not, but rather how to optimize management.
Exactly.
How about ACE inhibitors and ART? Do you ever hold it?
So that has been given like entire one page. So the thing is, we are saying that if the patient has low blood pressure or like borderline blood pressure, where the anesthesia is scared about getting hypotension during the procedure, they have liberty to stop it. Otherwise, as a cardiologist, particularly for heart failure patients, you're going to continue all of it. Continue all of it. In fact, guidelines talk about maintaining the MAP of 60 and systolic blood pressure of 90. And if that is not maintained for more than 15 minutes, there is data to suggest that that's when the may start going low, on the other side because of hypotension. So we understand that it's like, two things, the medicines that are very good, but then hypotension, that's not good for our patients. So I think it's basically how your patient looks. If this patient is living in 80s because they have systolic heart failure, you might hold the ACE inhibitors and continue everything else because beta blocker withdrawing has an effect on outcomes as well. So I think ACE inhibitors are easy to take. But if that patient is representing 150s and you're bringing it down to 120, please continue it because you are ensuring best outcomes for perioperative
I think
period.
we have data, sorry to jump in the question, but it was recently presented in the ESC meeting, the STOP trial.
Yes,
The randomized control trial comparing stop or not to stop ACE inhibitor.
that's
and
exactly right.
Both were safe options. So
Yes.
if you have a patient maybe soft blood pressure,
Yes.
maybe it's not hard enough to stop it.
Yeah. So I think, there's like a whole page on ACE inhibitors, but essentially that's the essence of what, I said and Daniel supplemented. Yes.
Depends. Okay, Aldo Scanone and then.
Yeah, I have many questions, but I am just gonna return to one.
The consult attending for today, right?
I think the only question that I have is, I mean, many times you get this patient that has never been seen, and we see that in our community, and then you go through the algorithm and the patient has like a low functional capacity, not tested before, you get the BNP and troponin, which I understand is just for recertification. But let's say that, comes positive. So how, beyond risk estimation, so, okay, this patient is at a higher risk. Do you do anything about it?
Oh, yeah, there is.
Statins, I mean, otherwise, let's say it's not indicated. We don't have any hyperlipidemia.
No.
So you don't act upon that. You just say it's high risk, but then there's no.
No, this was the class 1 indication that I showed. Sorry, I had to go through a lot, so maybe I didn't pay attention to this, but that's class 1 indication to start statin in that patient.
In the troponin positive patient.
Absolutely. Class 1 indication by ASCVD, even if your troponins are negative, if that patient first time coming to you and you think that they're going to meet criteria for statin, here it is. This is diabetes here. Class 1 indication, statin naive patient that meet criteria for statin use. And we all know how bad ASCVD risk score is. So we are not going to go there. But anyways, if you meet criteria, you're going to start statin. In troponin positive, you're going to definitely, they say that at least aspirin and statin, if everything else is negative. But you're going to evaluate that patient with an echocardiogram. There's a clear indication, class 1 for echo. You're going to make sure they don't have heart failure. So you are going to, if that patient is coming to you for first time, and say, for example, you put the non-cardiac surgery aside, you're going to evaluate that patient the way you would evaluate them otherwise. And this is just to supplement. But if everything else is negative, they don't have diabetes, I'd be surprised if they have positive troponin without anything else. but you're gonna otherwise also manage their GDMT as if you are their primary care, like all the risk factors, because there's good data to suggest.
I understand that, but I think, let's say that you're ACVD and you don't have any indication for statin, it just happen to be positive. I mean, here in the community in the Bronx, you'll be surprised what you see. So then, even if you're ACVD, you don't have any indication for statin. So your ACVD is like low risk or, or borderline or whatever, and then you don't have any other indication for statin.
You are going to
Aspirin.
start them
And
for,
that patient has a low functional capacity, and then you get troponin positive. And you
Yes,
create a semi- you go-
absolutely. I mean, this is what we do in our Minoca patients, right? I see these patients when nothing else matters, but then, you start them on, because there's nothing else right now for troponin positive. And I think that, I tell you, that's the limitation we all have, right? Like, we don't know what to do with MINTs. All we know is that a worse outcome. So how do we fix outcomes? Of course, we're going to give them statin and one antiplatelet. And that's the thought. But, as next 10 years may be very different, we'll see.
Okay, so Dr. Jonathan Bradlow, and I'll repeat the question for the audience.
Yeah, so besides the holding of the medications, I think that, and this is great, and it expands really on the 2014 about essentially treating this as if you're meeting the patient for the first time without the surgery and doing the functional assessment. Do you have standard functional assessment things for things like the frailty score? Because you had the DESI, there was the frailty.
Yeah,
assessment.
there are 5 tools that I showed, and the best one I showed you, the clinical frailty assessment. I can go.
Did I see that?
Yeah, and actually it's very nice because, I think we discuss, okay, this got stuck. But yeah, there is, sorry. Yeah.
The
This
question
cost-
is how to assess frailty, right? If there
Yeah.
is standardized options to assess.
Obviously, the RCRI, there's the,
Yes,
there's the DESI, which could be made, yes. I could make that into a smart text.
Yeah.
by-
clinical frailty score. Yeah, you can do smart phrase for that as well. There is a table with it. And in fact, if you look at those 5 tools that they describe, they also describe how clinical frailty score perform better. Let's see if I can slowly go to that slide so that I can show you. Sorry. Taking its sweet time. But nonetheless, yes, I think you can do that as well. And in fact, we, even before these guidelines came out, we did it regularly for our TAVR patients, because it's important, right? Like our, any transcatheter option, you want to indicate that they're truly frail and you're going for that. So I think it's good that guidelines, kind of stressed upon it. Let's see. Sorry, guys. One more, and then we are there. I think this is it. So here we go. Let's go forward now. And that's the assessment tool. And the clinical frailty scale is the one that perform better than the other ones. So there are 9 categories. So I think you can make it a smart phrase of that as well and use it for other stuff as well, because it's been validated in different populations.
Felipe, question from Felipe.
Regarding the guidelines, now that the guidelines that the 2019, that compared to the ones in 2014, now that we have the coronary CT angiogram as type 2P recommendation, along with the stress test, what would you go for as a screening first? Do you do both, either or?
I'll repeat the question. The question, Felipe, is when to use CCTA versus stresses when you decide to evaluate for CAD?
So I think that's an excellent question. So 2024 guidelines give both stress testing and CCTA 2B indication. I will tell you that I'm biased as an imager because what are we asking here? We are asking question about left main. So, that is a straightforward answer, right? Anatomical testing does much better when it comes to the question of left main than guessing that, okay, do I have global hypokinesis because of hypertensive heart disease, or is this truly, ischemia leading to triple vessel disease, global hypoxia. So I'm biased. I think we need to see more CT data, and there are some trials going on just really show that benefit in perioperative period, because CTA vision showed that it was just overly sensitive. So they don't routinely recommend it. But I do think that if you think about, all the data that we have with ischemia and, courage, actually what we are asking for is question about left main. And although the prevalence of left main in society is low, if that's the question we are asking, we would rather go for anatomical testing, in my opinion.
I guess one thing I'll add on this, I think you need to know who your surgeons are, right? I mean, if you're gonna do CT and you're gonna find other things, you need to make sure that that's not going to preclude your patient from the surgery.
That's the main thing. So CTA vision exactly showed what you just mentioned. People were freaking out with other atherosclerosis that was not left main. So again, you need to have that understanding within your team that they understand what you are trying to do, right? Like they need to understand that other atherosclerosis is incidental atherosclerosis that you're gonna treat with statin. Left main is when you're gonna go for revascularization. And if that's not the case, then you're not going to do it, because unfortunately, there is data to show that whenever we do any testing, every 37-day delay in, doing surgery. And some of these patients, I mean, they may have, cancer, and that has spread in 37 days, right? So
this is the issue that we see all the time is, that somebody maybe has high risk markers, but they're going for colon cancer surgery. And, if you do a PCI, now you have 6 months of in somebody who probably will bleed. And you're going to delay definitive cancer treatment for 6 months because of a semi-elective PCI that wasn't necessary in the first place.
yeah, and I think this is where the Revas guideline you showed you for NSTEMI, GDMT is class 1, and it's been downgraded to 2A for Revas, which we had a lot of arguments in the group about how can you hold off, because we don't know if we are calling all ACS. Are all troponin ACS? No. And this is where like everyone is getting labeled as NSTEMI when we know in reality that they're not. So again, go back to like universal 4 definition of MI, figuring out if they have wall motion, their clinical markers, and putting it all together and act as a clinician. So there's a question about, like when cardiology consult is indicated. So guess what? We are staying in business because I mean, it's funny. I'll just tell you guys. So the guideline committee was mixture of internal medicine, anesthesia, surgeons, and cardiologists. And guess who was the most concerned about all these consults that were coming to us? The cardiology group. Like, how are we going to deal with this volume? And everyone else was like, no, we want the patient to be evaluated by cardiology. So I think that's the point. Although we are downgrading the recommendation for testing, we are saying, basically they would feel much better if cardiology has evaluated the patient. And I don't know what it is, but it was striking how we as a community were like, well, but where are you going to produce all these cardiologists? And I think this is where the concept of team incorporating, our NPs, and there was a whole argument going on in Europe, but maybe this is where that concept of team comes forward. How are we going to build the cardiology teams going forward? Because we clearly have indications to patients to be seen by cardiologists, our expert opinions on this. And we can understand this is complex, right? The IM guy would be like, I don't feel comfortable with these complex issues, or girl.
One last question, Daniel Lorenzetti.
Thanks, Purvi. That was a great lecture. You touched us a little bit on aspirin post-PCI, no? Again, in the ESC, there was a trial called ASSURE-DES that was presented, randomized control trial comparing both strategy after 1 year of the PCI with DES, without drug-eluting stent. And there was no difference in bleeding or ischemic event, only an increase in major bleeding in the aspirin group. So my question is, do you consider in those patients maybe to follow the statin if you have like a surgery that could have more higher bleeding risk?
In my clinical practice, no. We are in United States. There's so much legal, I mean, I think the problem is that it's a very heterogeneous group, right? In the clinical setting that we are seeing. You're right that, latest stents, they do, we probably do much better, but, it's just so much heterogeneous. If you write anything in the guidelines, I mean, this is already happening in community. How many people have seen MI because patients are not on aspirin, in perioperative period with PCI? I can tell you, I have seen a lot, and that like really scares me. That's one of the things. Even with CABG, like they don't put patients on aspirin, and you see massive MI. So I think that so far, you're right that, there is data to suggest that antithrombotic therapy would be lightened up. And maybe in 10 years, you're going to see difference. But, till we have that wealth of knowledge, until all the, old stents are out in, like done, and we don't have them anymore, and it's all new stent population, I think we're going to sit tight, in my opinion.
No, if your surgeon is confident on operating on aspirin, it's also.
Yeah, I mean, that's another
Because
thing,
that's
right?
what-
I always tell my patients, find a new surgeon that is feel comfortable, because, yeah.
Okay, thank you very much. This was wonderful.
Thank you.
We have food now, and thank you everyone for attending.
Better know, it's like,